Right. Very good afternoon and welcome. I think our chair has made us already very motivated that we have introduced ourselves, and I think my talk is all about this collaboration. I'm sure you might be keen to understand that how we were able to work together across the Atlantic to decrease the number of falls. But I think the key message you should take back from my presentation is how we were successful to develop that collaboration. So my theme would be, of course, around falls, but I would like to show you that how we were able to develop that collaboration, or rather very effective collaboration. I'm going to tell you a journey of our three organizations, that is Intermountain Healthcare, NHS, and Kaiser Permanente. Intermountain Healthcare is, of course, in America, and they have got, it is not for profit. They have got 23 hospitals, and NHS, and it was born in or established in 1975. Kaiser Permanente is again not for profit. It is in California, and they have got 35 hospitals, and it was established in 1945. And the NHS, as you might know from England and from UK, it was established in 1948, and in England we have got 169 hospitals. So that's a very brief introduction of those three healthcare systems, and then you can understand that what we were trying to achieve, that how best we can work together to decrease the number of falls in our own systems by learning from each other. This is the journey of our collaboration. It started with our will. And it might be a small little story that I was on holidays in San Francisco. While being over there, I felt, why don't I should go and visit Kaiser, because you heard Kaiser. So I called the Senior Vice President on Safety and said, look, by the way, I was at that point in time IHI Fellow. So I think that was my little bit of introduction to them, and I said, well, I'm here on holidays. If you don't mind, can I come and visit for a day? They were extremely welcoming and hospitable. They invited me. They lined up a number of people from each I can visit. So that was the start of our will. So then we started thinking that, of course, we have met. We need to work on something, and the question was, I will show you those questions, then the idea, then we tried to execute it, and then there were very good outcomes, and then we felt the collaboration is so effective, we need to work on new ideas. So in next few slides, I will show you the ideas and the execution and the outcomes. So this is the way it works. We divided our journey into three stages. The first stage was the will, and at that point in time, the question was asked, okay, what is the most common harm? And my answer was, in the NHS, we have got falls, 285,000 falls happening in 169 hospitals every year, and that's tip of the iceberg. They said, wonderful, because we are also having challenges with falls. So we had a common understanding. And then we wanted to know how we can track falls in our system. So that was our will. Then we went to the stage two, that actually what we want to do with our collaboration. And I will tell you the lessons we learned. Start small. Don't show your passion that you can change the world. Just say start small. So we started very small, I will show you later. But we were very determined, very focused during the stage 3 to 5, and then we end up with some very good results. And our methodology was start small. And the first thing we asked to each other, sorry, I need to bring Intermountain Healthcare into this. At that point in time, after my visit, there was a conference that was IHI conference. And I feel these conferences are excellent places to have new ideas and new collaboration. And Intermountain met with Kaiser, and they said, we are having some collaboration with the NHS. And Intermountain were very enthusiastic. They said, I think we would like to join in. And I've got a very good colleague over there, and he came online and said, Mahmood, I would like to join in. I said, please do welcome, but I think there are some rules that we need to be simple and focused. He said, no problem. So our first idea was, what is the common definition of falls? Because you start with falls, and immediately we realized that three different systems are using three different definitions of falls. So the first thing we did, we came up with a common definition of falls. The second question was, can we track the cost and the size of the problem? Again, there were some challenges. When you say cost, you do it in dollars and pounds and euros. And actually, what are you going to cost? So I will show you what we did. And then the most important thing was that fine, collaboration is good because there are few like-minded people who either met so-called during holidays or they were very keen to move forward, but this should not be seen like my project. It should be seen as an organizational project. How best we can use this as a lever to improve, to motivate the people within that organization. And I've just lined down clinical, finance, and a number of other people. So Kaiser did the same, Intermountain did the same, and we did the same thing. So I used it as a hook telling people, look, I need your help to get this cost data because my colleagues over there in so-called in America are asking me for this information. And the finance guy said, really, can I join in? I said, why not? Come on. So I think that's the way we developed a very good internal team, and that's the way we started with. Then, there were challenges. You cannot just say everything was very rosy. So we had some challenges. We started with saying by simple definition, but then we realized that we need to have some leverage that how best we can compare data, because it is not good enough to say that your data is better than mine. And I think we have to establish some common grounds that because we have got very different systems. And then the issue again came that, okay, when we looked at falls in America, because we have got a better costing system than the NHS, we looked at every cent and every dollar. And over here, because it's the public-run system in the NHS, we are not able to see how much that fall is costing us. So I personally and our number of organizations were very keen to learn from America. On the other side, they asked me that because you have got a very clear definition of falls, and we have got 4 categories of falls in England, and they said we would like to adopt it. So you could see that we were learning from each other from the very outset. And these are some results. And you could see the first thing we wanted to compare, that how we are comparing our number of falls. And we used 4 categories being used by the NHS. No injury, minor injury, moderate injury, and major injuries. And you can see the color coding is the NHS is blue, Kaiser is red, and Intermountain is green. And we just realized, yes, there are some differences and there are some commonalities. Because of shortage of time, I do not want to go into detail. And then the other thing we wanted to look at, how are we doing with cost? And we came up with a common currency. Rather than saying how many dollars being wasted and how many pounds being wasted, we said we will use the common currency of extended length of stay. Because this might be the common currency which says if you have got a minor fall, a major fall, or minor, moderate, major fall, how many days that patient stayed in hospital, and if you can cost in your own system of that 1 day stay, that should be good enough. So you could see that we had very good results, and the trend is very similar, that I think the higher the injury, the longer you stay, but I think there were some differences. And then, of course, we were not only doing this collaboration for sake of just learning from each other. We were very keen that our collaboration should bring some good results for other healthcare systems. And we came up with this 4 recommendations. The first thing, as I told you, we felt there need to be, when we start looking at each other system, look at the falls, we realized the American colleagues were using ICD-9 coding and the NHS is using ICD-10 coding. And then we realized that even in ICD-9 coding and 10 coding, there are no clear definition of falls. So our first big recommendation is to WHO. We are going to work with them so that in future, if you would like to do a comparison with any other country sitting over here, at least we should be going to use the same ICD code. So I hope by the time ICD-11 code comes out, there will be a standard code for the falls, inpatient falls. Next thing we learned that this work, when you work together, clinical and finance, it needs to help to build the business case for quality. It means that if you can show that what is this fall or this harm is costing you, then at least you can prove to your clinical colleagues saying, if you can reduce those falls, it will save money and we can use that money to save more lives. So that is business case for safety. Third thing we realized that the extended length of stay is a good indicator across the globe because wherever patients are falling, they are staying much longer in number of hospitals, and if we used it, it might become a standard. And then last but not least, we realize that international collaboration is a wonderful way to learn from each other, but you need to be having a very common focus. But this is important. When I say international collaboration, there are a number of lessons we learned as we went through our journey. First thing was we need to have a very simple objective. Second one, it should be a very staged approach. People are sometimes keen to do things in a very fast manner because they have got more enthusiastic people than I had. But I think if you say that these are 3 stages, then people can catch up. The third thing that we need to have a very proactive coordinator, and our colleague from Kaiser, she did an excellent job. She kept us on our toes, but she was acting as a hub for information, because you need one person who could act as a hub. Fourth lesson was we need to develop some common grounds. It is not good enough that you are doing a collaboration. Our common ground was what is the size of the problem and what is the cost of the problem. And then last but not least, that you need to act as a team. And you may laugh that that was the only one visit I made to Kaiser. Rest of everything was done on the WebEx. So we are having only, every 6 weeks, we are having those WebEx. Diane from Kaiser, she did an excellent job. She just arranged it. And we, because there was a difference in time, 8 hours, but it worked so well because it was 5 o'clock in England, and it was 8 o'clock in California, and I think it was around 11 o'clock in Utah. And I think that's the way the time worked in our favor. And I would like to acknowledge, because I am standing here to represent all of those, and I think all the good work was done by a number of people, and I think I had the privilege to stand over here to represent them. And my other colleague, Pascal, he couldn't manage to come, otherwise he would be standing here beside me. So it is not an effort of one person, it is an effort of a number of people, and they were very dedicated with common purpose, and the purpose was we need to learn from each other for sake of our patient. And that's the way we were successful. Thank you.
Thank you so much. Any question? Yes, please.
Thank you. Mary Seddon from New Zealand. So we've faced the same problems about definitions. Has your collaboration gone on to actually run improvement or prevention programs with falls?
So you're asking about what we have done about intervention?
Yeah, because you've presented the starting building blocks of what needs to be done first, but presumably you're also going to learn from each other on what works and what doesn't work in preventing falls.
I think you're very right. What we have done, we asked all 3 healthcare systems to draw the fall map. And fall map was very simple. What happened before fall, what happened during fall, and what happened after fall. So when we did that, we came up some paper-based intervention, like assessment, high risk, those things you do, and some real physical intervention. Like in the NHS, we developed a tool called Team Red. So it means we had to look at the toilet lights and all those things. So when we looked at those 3 maps, that what is happening before, during, and after fall, we started realizing that some preventions are working in one system more effectively as compared to others. And I think that's the way we learn from each other. And because I have the data, but this is not the purpose to show you the intervention, but that's the way we are learning from each other.
Any other question? No. Thank you very much, Dr. Adil.
Thank you.
Thank you. While Dr. Ohde comes to the podium, please. If you, in the meantime, can introduce yourself to another colleague, so we really connect and add our connection. Nobody wants to introduce himself.
Bonjour. My name is Sachiko. I'm from St. Luke's International Hospital. I am going to talk about the efficacy of a multidisciplinary QI activity for accidental fall prevention. Staff compliance is critical. Inpatient fall is a very important issue. It is because it's a substantial cause of hospital injury. It could result in extended length of stay and decline patients' quality of life. And it occurs in as many as 20% of inpatients. There are numerous experimental studies on falling prevention. However, the staff compliance with multifactorial interventions are varied, and the results are varied too. I cited 2 RCT studies here. Called RCT 2007, their compliance rate of experimental group was 77%, and the result was multifactorial intervention was effective. Dykes RCT 2010, their experimental compliance rate was 81%, and their results was not effective. And then RCT's compliance rate is always higher than real clinical settings. Ewigman, 2006, they did an observational study about multifactorial interventions for falling prevention. However, they failed to show the effectiveness. And they cited one of the reasons was low compliance rate. So we decided to implement multifactorial interventions program. We call it QI activities, with especially focusing on the staff compliance in the routine clinical settings. Context and methods. Clinical context. Before QI activities was implemented at our hospital, inpatients' fall rate was approximately 2 per 1,000 patient days. Our goal fall rate was 0. QI activities for inpatients for fall prevention was implemented from 2007 to present. Patients. We targeted all adult inpatients except maternity, health checkups, and intensive care patients. Location. We did this study at our hospital, St. Luke's International Hospital in Tokyo, Japan. We have 520 beds. We are a tertiary level acute care hospital. Our hospital's detailed information is in your handout, so please go to the printing room after this presentation and you get the more detailed information. Staffs. There are 3 groups and committees very importantly involved in these QI activities. One of them is a working group for falling preventions. Working group for falling prevention was generated by the multidisciplinary staffs and who are voluntarily gathered, who are interested in decreasing the inpatients' fall rate in our hospital. QI committees and patient safety committees took a responsibility for monitoring for compliance rate. A brief summary of our approach. Detailed information for the activities are in your handout. However, I'm going to explain briefly. Our QI activities has 5 components. Activity 1 was the fall risk assessment. Working group developed the falling assessment. And first, we did the literature review, and we selected 13 items. Subsequently, we keep statistical analysis, and we try to decrease the items as few as possible to achieve the clinical applicability. Activity 2 was intervention protocols. Working group planned the intervention protocols based on the results of the falling risk assessment. Intervention protocol was applied to the patients at the risk, and the patients at the risk where patient education was provided. Detailed intervention protocol was on your handout too. Specific environment. Activity 3 was specific environmental safety and interventions. Members of working group reviewed all the rooms of our hospital, and we eliminated the steps-offs, and then we added handrails. The place where it was difficult to add the handrails, we utilized the best position bar. Staff educations is activity 4. What we are doing as a working group, those information were provided to all staffs. So members of the working group provided the staff education every year, and we share the information how to utilize the falling risk assessment and intervention protocols, recent cases of the falling in our hospitals, and also recent studies in the world about falling prevention. We also provided to the newcomers of at the orientation, we provided the newcomers how to use the falling risk assessment and how to use the intervention protocols. So everybody, all the staffs at the hospital know about this prevention program. Activity 5 is most important part, I think, because we are looking at compliance rate is higher. So QI committee and patient safety committee took a role for the monitoring processes. QI committee, they meet monthly and they monitor how the falling inpatient rate was every month, and they provided the feedback to each ward. Patient safety committee, we meet every day and we review the all incident report over 24 hours, and we provided the prompt feedback and monitoring. Results. We started this QI activity on 2007. As you see, before QI activity, falling rate was approximately 2 per 1,000 patient days. After QI activities, it is going down, and it's now, 2011 was 1.38 per 1,000 patient days. The two tables here is about compliance rate. Patients assessed at admission on 2007 was 91%, but now it's really close to 100%. 2011 was 97.2%. Patients provided medication. It was 88% when we started to record on 2009, but it's now over to 95%. Lessons learned. When correctly implemented, multidisciplinary QI activities are effective. Our compliance rate was substantially higher than other studies. We think 3 reasons. First, result of a consistent long-term and short-term feedback and monitoring processes by QI committee and patient safety committee. 2 is a robust falling risk assessment tool development with easy clinical applicability, only 6 items. And 3 is staff education, group buy-in with staff involvement and education at employment orientation and every year. This is all I have. Thank you.
Any question? Comments? Yes? Do you mind? Oh, okay, I come.
Thank you so much. Thank you so much for the interesting project. However, I have a question on your excluding criteria, your inclusion-exclusion criteria. You have excluded maternity patients. I was just wondering why. Thank you.
At that time when we started to this project, we only targeted the ill patients. So we thought maternity patients are not really ill patients. So we excluded because we thought that's different population. But actually, this QI activities is just keeping evolving. And now from 2012, we are including maternity health patients too.
Yes, hello. My name is Nina from Norway. Can you please tell me a little bit more about the risk assessment tool? When did they do that? And how often? And did they get to see the patient who was in term to falling?
Okay.
By using it?
Maybe you can pick up the handout at the printing room later. I added more detailed information with the flow chart, but just brief. So at the admission nurses, when the patients get admitted to the ward, all adult patients who met the inclusion criteria were assessed with the only 6 items, and it is a template on the electronic medical record. So it automatically pops up, and then everybody, all patients are supposed to be assessed. And then if the patients at the risk, those patients at the risk will be reassessed regularly. And then even if the patients who are not at risk, they also get reassessed if the patient's condition got changed.
Thank you. Any other question? No. Thank you so much, Dr. Ohde.
Thank you.
And now let's do Dr. Anderson. Please take the podium. And in the meantime, please introduce yourself to someone else. We need to connect. Please just say hello.
So is everyone good friends now?
Community.
It's all community, that's right. We're all one big family now. Thank you for having me. This is certainly a pleasure to be here in Paris, sharing our story with you. I would like to share the story, what we have predominantly related to how we are organized in quality at NorthShore University Health System in Chicago. As you can see, we have about 1,100 beds. We have 1.2 million office visits. We have a fully deployed electronic medical record from the outpatient side to the inpatient side with many millions of encounters. And from those encounters, we have deployed what is called an enterprise-wide data warehouse that allows us to look at analytics related to any number of clinical activities. And I'd like to show you some of these as related to falls and how we began to use those analytics. We are the major teaching affiliate with the University of Chicago, in Chicago, Illinois, and have received a number of awards from a variety of United States quality institutes recognizing the activities associated with quality. When I mentioned earlier that I'd like to talk with you briefly about how we organize for quality, it is very important to have that context to see how this project worked at NorthShore. We believe that quality comes in 4 dimensions. The first dimension is quality control. We have a number of agencies and organizations who look over the quality at NorthShore that are federal and state organizations, both from the United States as well as the state of Illinois. And we have voluntary accreditation from the Joint Commission, who is represented here at the Joint Commission International. So that's quality control, the basic building blocks of making certain that quality is in place on a day-to-day basis. The second aspect of quality we have is performance excellence, where we have teams of people working on small cycles of change and improvement from day to day, week to week. These are many of the multidisciplinary teams that you've heard about today already, but incorporates groups of doctors and nurses and therapists and administrators who all come together for the purposes of evaluating a problem, designing the solution, and measuring results associated with that. But the last 2 that I'd like to share with you is what makes, I think, our approach somewhat unique. The first is associated with quality through development of people. How we have all 9,000 of our employees engaged in quality from a day-to-day, moment-to-moment basis. And towards that end, we have developed formal programs for our physicians, our doctors, to become trained in quality. And these are quality fellowship programs where there is a specific curriculum and a specific opportunity to lead projects so that they have an opportunity to gain some success and the belief that they can actually participate in and help solve problems that are occurring at the bedside. In addition to physicians, we also have these programs established for our nursing staff. So they believe that they can lead teams related to quality improvement project work. The last domain of our quality program at NorthShore is associated with quality through innovation. And it is through this innovation that we've used the data warehouse to describe the analytics so that we can actually capture improvements and then deploy those through the electronic medical record. We believe that by hardwiring those improvements into the workflows of daily patient care, that we can more successfully predict the likelihood of a positive outcome if it's day-to-day improvement. So I'd like to show you briefly what we looked at with respect to 3 cycles of change for improvement in our Falls program, focusing on specific interventions we made and describing some of those analytics that led to what is now our research phase of the predictive analytics that we have for falls prevention. So when we began the multidisciplinary teamwork, this was the first cycle of change, and we noted that our fall rate was in fact within range for what was nationally published data, but we realized that the nationally published data was probably not robust. It was not robust because many falls are not reported. I think, as Mahmood said, it is very difficult to get common definitions. The second thing is that we find that people don't report things that happen day to day. Would anyone like to take a guess as to when the Office of the Inspector General in the United States evaluated the number of fall incidence reports to try to determine what percentage of those falls were actually reported? Would anybody willing to take a guess about, is it 50%, 80%, 40%? What would you like to take a guess? 25%. 50, 25, 30, about 14%, which means about 1 in 7 falls are actually reported. That means about 6 out of every 7 falls are not reported. So it was very difficult. We realized that even though our fall rates were within some range, they were not good enough because we weren't probably doing a good enough job of assessing ourselves either. So this concept of underreporting we had to address through educational efforts with our nursing staff and others, and creating an interdisciplinary corporate falls prevention team, a group of people who had the passion for making certain that the interventions were carried out on a day-to-day basis at each of the individual units where they worked. Now, in response to this, we did see a decline in our global fall rate by about 22%. This was an improvement, we believe, because we sought greater reporting, which we got, and we sought greater reduction in our falls prevention. So overall, 22% reduction was an improvement. We felt strongly that that was a step in the right direction, but not the end of the path. We did find also, as we looked at our risk management data, that the severity of the falls diminished in terms of the number of injuries that were moderate and severe. As you've seen from the other 2 previous presentations, today our data were similar. Phase 2 of this next cycle of improvement then was looking at what could we do to assess our patients on admission and thereafter to see if they were perhaps at higher than average risk. And we adopted a scale. It was called the Schmid Scale that came from the Department of Nursing in 1990. It described a few elements that were consistent with patients who might be suspect for falls. Each of our nursing staff completed that competency assessment, that they were aware of how to use the tool and its importance in recognizing patients who were at risk of falling. In response to that, we had an opportunity to deploy a number of opportunities, including each time a patient would fall, we would have a post-fall huddle where the nursing team would work together to say, what is it we learned at this exact moment? So instead of just aggregating and looking at it a month or 3 months or 6 months later, we wanted to know exactly what happened in the previous 5 to 10 minutes. We started some of the common practices that were associated from IHI that were best practices. Things such as arm's reach distancing. For example, we found from some of our early work that one of the greatest risks was when a patient felt they had not had an opportunity to get up with assistance, they oftentimes would get up on their own and would fall. The second greatest place for falls occurred when they were at toileting. So arm's reach assistance was that always the patient was going to be within reach of another human being who could support them for changes in position. We educated our patients and their families on admission and at every shift, and we began to use bed and personal alarms to help recognize those patients who might be getting up and out of bed on their own. We then put forward nursing grand rounds. We distributed this broadly across all 4 hospitals, all 1,100 beds, all 9,000 of our employees. And then we baked this in, or hardwired this into our electronic medical record. One of the things that we began doing with our analytics was to assess those patients who were falling. And we realized that we probably had a robust data warehouse that we could begin looking at an enhanced predictive modeling system so that we could better recognize patients who were at risk of falling. So in fact, instead of just relying on what had been historically the Schmid Scale, we wanted to say, is this consistent with life at 2012? And so we found through some of our risk modeling that we did find that patients who were in our system, who were greater than 85 years of age, who had osteoporosis, who within 2 days of having an operative procedure, and who had changes in their hematologic condition from low platelet counts or increasing bleeding times and so forth, were the ones who are most at risk of injury, of severe injury. The two major kinds of injuries we saw were fractures, predominantly long bone fractures, but we also saw significant problems with central nervous system bleeding associated with falls and head injuries. So we thought we had an opportunity then to change our electronic medical record, and this is one example of a page in the nursing record that you can see at the top. The fall risk scale is included, that includes things as the nursing assessment of mobility, mentation, numbers of and types of medications used, elimination habits when they're toileting and so forth, their prior fall history, and so forth. And then the nurses begin to look at whether or not these risk factors are present that might produce injury as well. In response to this, we've been able to see some favorable improvements in cycle 2 and cycle 3 of our performance. And right now, our falls with injury severity rate is down at about 0.3 per 1,000 patient days. Our total fall rate is down now about 1.4 falls totally for all of our patient population, excluding an intensive care unit, per 1,000 patient days. So in conclusion, what we found at least one hospital health system in the United States was that we could create a safer environment by creating heightened awareness and then implementing a consistent plan of care. This plan of care is something that is a part of the handoff communication that occurs with each change in nursing shift, or if a person's clinical condition changes, or if they move to a different transition level of care with any of NorthShore's institutions. The electronic medical record and its tools can provide valuable adjunctive assistance to clinical nursing staff at the bedside by having a fall risk banner that's in every patient's electronic medical record header, and by having tools that are baked into the electronic medical record that in fact signal the communication to our patient's caregiving team from shift to shift and change to change. And lastly, we've been able to use analytics to assess predictive modeling variables that are associated with patients who have much higher than average risks of fall, and by better defining them at NorthShore, we can better recognize them to prevent falls. The final part that we got, which we didn't really necessarily expect, is that we have had a dramatically enhanced reporting culture. People began to feel that it was their part of the problem to own. And it goes back to those 4 basic tenets of quality that we have at NorthShore, and the team-based approach using those trained to own quality at the front line is what I believe that we probably got the greatest amount of yield, because not only did that benefit us in our falls prevention program, it helped with any and all of our other quality improvement programs. With that, that's my conclusion. Thank you.
Thank you very much. So, any question? Yes.
Could you tell me how you? Thank you. Could you tell me how you operationalized your arm's reach up portion? Because older, confused adults who fall with serious injury are a big issue.
Sure. The question was about how do we put into place the Arms Reach initiative. The greatest place where that Arms Reach initiative has helped us is in the toileting arena. Because when patients get up on their own, we know that they're at risk of falling. So we educate them and their families at the beginning. If they begin to get up and they're not supposed to be up without assistance, that's where the personal and bed alarms will help give us the warning so we can get to them more quickly. And then lastly, we do hourly rounds with our nursing staff, and one of the key questions that's asked is, do you need to get up with assistance to use the toilet? When the patient says no, we don't necessarily still believe that. That's the personal bed alarms, folks. But we do ask them if they need to get up. We go with assistance, and we hold one arm distance through the door of the toilet that's there in the patient bedroom.
Sorry. Hi there. Thanks for your presentation. I was wondering if you could say anything about how you weighed up the two improvements you were trying to make. An improvement in reporting culture, which obviously, if it was accurate, you would have multiplied your amount of falls by 7, versus trying to measure improvement at the top of the organisation. How did you manage those two things? Because presumably, at the beginning, you wanted your falls rate to massively shoot up. And how did you explain that to the top, as it were?
That is certainly a great question, because it is tempting, I think, to look at only the numbers and look at the slopes of the curve in decline and imagine that that is the descriptor of success. And in fact, as you allude, it is very important. First, when you're beginning a reporting culture with a greater transparency, you will find initially a rise before you'll get a decline. It was my job as the Chief Medical Quality Officer to make certain that our executive leadership team and our board of directors understood that before it gets better, it must appear worse. We did this also in looking at physician behavioral issues, where we believe that it is a strong component of a patient safety culture that our physicians should contribute to the team equally along with our nursing staff. Well, we had a certain degree of noise that came with people reporting physicians who they felt weren't necessarily behaving well and participating in their safety culture. We found that that number dramatically went up. Instead of panicking, everybody said, this is what we should be expecting to get. So it was impossible in a research study to do a controlled trial, because we knew we were going to get a rise in our reporting level, and we did not know what that noise meant as the fall rate would increase.
By the way, look at that chair. There is a danger, an hazard for fall.
Hello, Siobhan Dennehy from Toronto, Canada. I had a question. You were mentioning about competency assessment for your staff, for the nursing staff, and then you mentioned around training of nursing staff in the use of the tools and the interventions and the huddles. I'm interested, because I'm an occupational therapist, what your focus was with other members of the interprofessional team in all of those areas.
Each of the areas of the discipline of caring for the patients received the identical education and training. We felt that this was really representative of a multidisciplinary team. We felt that the captain of the ship, so to speak, was the nursing staff, because they were around the patient every moment of every day of the week, day, night, and so forth. But we did not decline to engage all of our other staff members in that education as well, because we felt it was the responsibility of anyone who entered into that patient's room. It was his or her responsibility for the patient at that time. And I think in that sense, we began to broaden our safety culture, because we then believed that it was, one of the hospitals adopted a slogan, that it was called, not mine, not yours, it's this patient is ours. And I think it became very rich, that people understood that it was everyone's responsibility to care for the patient at the bedside. So we deployed it fully across all the disciplines. It was abbreviated, and a message carried forward by therapists to other therapists, and predominantly the heart or the core of the measure was for nursing staff.
Other questions? No. Also, yes, please.
Hello. This is for all three, probably, because in Norway we try to, where I work in a local hospital, we have seen how to do this, and we take contact with Oliver, who has tried to do the Stratify, if you heard about that one, the assessment tool, and he said to us, the tools, assessment tool, don't work. It is not good enough. It is the clinical scene, and you have to work at. Can you say something about that?
Yeah. I'll start, and I'll turn it over to my two other speakers. Absolutely, I agree that the assessment tools that have been made available since 1970, 1990 are very inadequate. And that's why when we looked at our predictive analytics, we realized that we knew at NorthShore the population of patients who were most likely to fall. We found this for other models, congestive heart failure, where other accepted models. We ran our patients through those models. It didn't work. So we had to do the analytics using our own patient population, using the data warehouse to identify those real risk factors that our patients had.
David Oliver is a very good colleague of mine. I think you referred, I think he's right. He has published a lot saying that these are, and to some extent in the NHS, it is very right. What we have done, we have come up, when we looked at not only this collaborative project, because this is going on all across the NHS, the falls, we realized that how much time nurses are spending filling those forms. So the opportunity cost, and then on top of that, if David Oliver's recommendations are right, then it means we are losing on both ends. First, the validity of the tool is not authenticated. On the other side, the nurses are filling the form for a false reassurance that, yes, I filled the form, I have identified it. So what we have come up with just simple 4 questions. And this is a simple 4 questions which can, the sensitivity and specificity of those questions are as good as could be any other of those 3-4 tools you're talking about. So you can download those 4 questions or email it to me, I can send it to you. So most of the hospitals now, they're moving away from those particular tools or assessment tools, but they are just doing those 4 questions.
Any other question? May I ask the speaker where and how can we learn more from you? Are you going to publish? Can we get in touch? How can we learn from your experience?
Well, we have put our nursing teams have published in America.
Okay.
We have won some awards related to their publication, and we will certainly have this available through IHI.
Wonderful.
And it's a bit of a longer presentation. It includes some of the ideas related to our, how do we set up our 4 prongs and our tenets of quality and so forth.
Thank you very much.
As you know that in England we have got NICE, National Institute of Clinical Excellence, and they looked at the example of best practice and they sift them through. And the work we have done in the NHS on falls, it has crossed all the barriers and hoops, and it is on their website now. So, because this presentation wasn't all about my work in detail, but this is on the NICE website and all those things. And even NICE has done the costing bit as well, that if you follow this tool, how much you're going to save. And it is called Stepwise Guide, because all those things are, if you Google Stepwise Guide, Mahmood or NICE, I think you will find it.
So all information, more detailed information is in my handout, so please pick up the handout. And also we are preparing to publish the paper, and we are supposed to resubmit next week, so you will be on the PubMed.
Thank you very much. And please also, we are looking to learn from you. So please share your experience with us next year, and perhaps today with the other colleagues you have met here. And before leaving, once again, introduce yourself to someone else. And let me finally thank you again, our speakers. Thank you very much, and have a nice final afternoon.